We have an amazing session coming up next. So without further ado, I'd like to welcome our sponsor, Coram CVS Specialty Infusion Services, as they present Ask Me Anything. So at this point, I will turn the program over to Amy Braglia-Tarpey.
Thank you, Andrea. Can everyone hear me? I hope so. It looks like I'm off mute. I'm notorious for double muting and undoing that thing. So thank you for coming back and joining us today. I'm really excited to introduce our panelists. So I am going to go in order here from left over to right and on down. We have Michael Medmar with us, who you've already met. He's Coram's patient advocate. To my right on my screen, we have Cynthia Reddick. I'm so delighted to have Cynthia here with us. She's our National Director for Tube Feeding, has been a dietitian for many, many years, and her nutrition superpower is ensuring that the relationship with your tube remains intact despite any challenges. So she'll talk a little bit more about that, I think, at some point. And then we've got Leah Befka. Leah Befka is the lead dietitian with Coram. She's been with us for almost 5 years and has been a dietitian for 11. She lives in Colorado Springs, Colorado. That is a lead dietitian, gets to help out all around the country. And her nutrition superpower is her ability to teach peers and work the same question from different angles to better understand, to better help people understand new subjects. And then Janelle Flaherty is also a dietitian, but Janelle works with our tube feeding patients. And Janelle is the manager of Coram's enteral operations for the dietitians and Medicare qualification teams. She's been a dietitian for 14 years, working with tube feeding patients with Coram for the last 12. And she lives in Cascade, Idaho, which is 2 hours north of Boise, and enjoys the snow there. Janelle's superpower is the knowledge of enteral parts and pieces and troubleshooting feeding tube connection issues. And then also with me today is Dr. Mark DeLegge, who needs no introduction. He spoke to you earlier about preserving your vascular access. He's Coram's medical director and a true longtime expert in both TPN and tube feeding in the home setting. And then also with us today is Sarah Simonetti. Sarah Simonetti is a corporate clinical nurse with Coram. She has been an infusion nurse for 25 years, and she has worked with Coram and preferred home care for 20 of those. She's a leader on our corporate clinical team, and her superpower is simplifying the care and maintenance of IV access catheters. Last but not least, not on our screen, but with us today, unfortunately, she doesn't have a camera on her computer because we'd love to see her shining face, is Crystal Wilkinson. Crystal Wilkinson is a pharmacist on our Coram TPN Excellence team. She's been practicing pharmacy for 12 years and has been with Coram for 8. She's licensed in California and Missouri and based in San Diego. And her superpower is helping to ease patients and caregivers' anxieties around TPN at home upon discharge from the hospital. So thank you to all our panelists for joining us. I don't want to waste any more time. I want to dive right into the questions because we got over 50 questions in advance of the conference. I do want to remind you that you can still ask questions if you didn't have a chance to ask them in advance. We'll get to as many as we can, but certainly don't hesitate to put those in the Q&A section and we'll pick them out if we see them there, okay? Let's get started. I am a dietitian by background, so you know I'm going to start with the nutrition question. So the first question we have is, what is the formula to make Gatorade G2 into an oral rehydration solution, or ORS, in a pinch? I'm going to send this one over to Leah, who's our infusion dietitian.
Thanks, Amy. So yeah, this recipe is super simple. It's just 2 cups of G2, 2 cups of water, and 1/2 teaspoon of salt. Simple, easy enough.
Great. And Leah, if you have a minute, you could put that in the chat too, and maybe people can copy and paste it in case they need it. Thanks, Leah. All right, so let's follow that with the tube feeding question. Are there any bowel management products used for tube feeding tolerance, or should the formula be changed? Janelle, can I send that one over to you?
You can. Thanks, Amy. And that's a great question. And so for me, when it comes to bowel management, I never want someone to have to be on a medication if they don't have to be. So I'm always going to look at what are they doing first. And so if it's constipation, let's say that they're having an issue with, when you think constipation, think hydration. That's the first thing I'm going to look at is, are you getting enough fluid? Because that can often lead to constipation. I'm also going to look at medications, because there are a lot of medications that their side effects are constipation. And that's important for us to know in determining what the best solution is going to be. When it comes to formula, we may look at adding more fiber, taking away fiber. But in some cases, let's say if it's a drug-induced constipation, and you'll get that a lot if you're on a lot of opioids or pain drugs can cause constipation. In those cases, changing the formula may not help. And that might be the situation where you want to talk to your doctor about a bowel management medication. When I'm looking at diarrhea, I'm going to look again, are there medications or infections causing that diarrhea? I'm actually going to look at the feeding regimen. Are you feeding too fast? Are you feeding too quickly or too much volume at once? Are there things that I can change in that formula regimen that are going to help control that diarrhea? And then again, if I think changing the formula is going to help, I may go that route. And if not, then I'd look at adding some bowel management stuff. And you'd work with your doctor to determine what type of bowel management would be best for you.
Yeah, that's great. We had another tolerance question, Janelle. We had someone asking, why has my partner developed so much reflux since having a peg placed? And maybe Dr. DeLegge also has some input on this one, but I'll go to you first, Janelle.
Yeah, kind of similar to the bowel management question. I'm going to again look in to see, is there something causing the reflux? So did you have reflux before having the tube placed, or did it just come after? So is this a long-standing thing where there might be a medical condition, or is this something new? If it's new with the tube feeding, I'm going to again look at your regimen. How fast are you feeding that formula? How much are you feeding at once? Because just like if you eat too much or too fast, you get reflux with an oral diet, you're going to get the same with tube feeding. And what I sometimes find is, we know you guys at home are busy. You want to get that food in fast, and you want to get the feeds done. You don't want to have to do a lot, which I get, but sometimes reflux can be a result of that. So it may just need to slow down or do smaller, more frequent feeding to help with that. It could be if you have a condition that you do need to use a proton pump inhibitor or an H2 blocker that you'd work with your physician on. But again, I'm always going to go to the regimen first. Is there something I can change there to help with that reflux? And one thing too is positioning. When you're feeding, is your head of bed up? Are you elevated so that you're not having the formula reflux with your feeding?
That's great. That's great advice, Janelle. Great advice for all of us, not just for people on tube feeding, right? You struggle with reflux. Dr. DeLegge, anything to add?
No, that was great, Janelle. I don't have anything to add.
Great. Another tube feeding question just came in live from Kelly Baker, and she wanted to know what are some of the best or most tolerable enteral formulas for GI motility disorders? Do you typically recommend specific formulas, or is it really based on the individual patient and their other needs besides their motility disorder?
I think it definitely is patient by patient, because everyone's anatomy is a little different. I'm going to look at where that tube's being placed. If they have, let's say, gastroparesis where the stomach's not emptying, are we feeding past the stomach? Are we feeding into the stomach? When you have something like gastroparesis, you're going to want a lower fat formula. You're not going to want a whole lot of fiber in there because those all slow down digestion even further. So, you really are going to want to look individually at each patient to decide the best formula for them and what's going to work for them.
Yeah, safe to say it's probably something to bring back to your dietitian with questions specifically because they'll really know your case. Yeah. Thank you, Janelle. Okay, so we had another question come in, and this one is related to TPN. So I'm going to send this one over to Crystal, who's one of our Coram pharmacists. One of our patients asked, how often do you require labs in TPN adjustment. So maybe you could shed some light on what that typically looks like, Crystal.
Sure, no problem. It's a great question. Initially, when patients start with TPN at home, we would like to do a weekly monitoring of their labs just to make sure that they are stable and there's no additional adjustment that needs to be done initially. After a couple of weeks, if they're stable on their formula, we will discuss with their prescriber if we could switch the labs to every other week. And if they're stable on those labs for approximately 4 to 6 weeks, then we'll discuss whether or not the physician is comfortable changing it to a monthly lab. We'd also discuss it with the patient as well to see if they are comfortable with doing labs that way as well. Of course, we would also have as needed labs for our home health nurses to draw them as needed for certain situations where they're warranted as well. So.
Yeah, I think, if you, I don't know if the person who put this question in is with us today, but, you want to think about if this is a challenge for you getting your labs drawn, for example, if you don't have a home nurse who can draw them and you have to go into a clinic or a lab, really work closely with your prescriber home care company to decide what's the right cadence for you, especially once you're stable, and then there may also be times, where your physician is investigating something that's, going on with you currently and may want some additional labs. So it can vary a little bit. Thank you, Crystal.
No problem.
All right, we're going to shift back to tube feeding. I've got a question here for Cynthia, who really is our tube site expert around Coram. So someone is asking, do you have any tips for excess granulation tissue?
Thank you for asking this question. This comes up a lot, and I'm going to also invite Dr. DeLegge to comment. But the first advice I have is to address the issue. I think there's a lot of patients out there that are told that granulation tissue is normal and just sort of leave it alone. But what I have found is that granulation tissue presence is at minimum uncomfortable. And so I think we forget about that as clinicians. What life is like with granulation tissue looks like discomfort. It feels like pain in some cases. And that granulation tissue is also what I refer to as an ooey gooey factory. It creates an ooey gooey mess that you have to manage and live with, which I'm not a fan of. So the first thing you need to do is address the cause of that hypergranulation, and that requires you making sure that your tube is fitted properly and that it's secured properly. So if you have a dangler style tube, make sure that that external bolster is set properly so that the tube is secure and stable. And then if you have a low profile device, make sure that your button fits properly so that you don't have excessive movement. When you have a feeding tube that's moving, in and out of the stoma, that friction will cause hypergranulation. So there are ways to address it. There's several ways. A conservative way to address hypergranulation is with a hydrocortisone cream application, and that's something that you have to be careful about the application, but it's a home care friendly option that is typically very effective. Some patients don't respond to that, and so we will consider silver nitrate at that time, where some clinicians will go straight to silver nitrate. It's not my preference. I like to try beating it down with a hydrocortisone cream, but some is resistant, and then you might have to go to that silver nitrate, or if the granulation is too large, it may need to be debrided. So I know Dr. DeLegge is going to have something to say on this, so I'd like to hand the ball to him.
Actually, you've done a fabulous job. So that sounds like a very practical approach to granulation tissue. Amy, you're on mute.
You did it.
I did it. I can't go by a whole 30 minutes without getting myself talking on mute. Okay. Lots of tube feeding questions today. I know we've got a lot of people here with burning questions. We've got another question about granulation, but this relates to the port site for TPN. So I'm going to ask Sarah to weigh in. And they're asking, is it normal to always have granulation at the port site? And even with silver nitrate treatments, it never fully goes away.
So like Cynthia mentioned earlier, granulation tissue is relatively common at feeding tube sites, and it does develop less often at infusion port sites. some individuals are more prone to developing granulation tissue than others. And the tissue is caused by the healing process, and it can increase with infection or pressure or irritation. So the advice that I can offer about port sites is going to center around prevention, strategies to minimize the tissue development in the first place. And that would include ensuring that you're using the correct needle length to avoid any excess protrusion from the port. Then finding a way to secure the needle and prevent pulling and rocking at the insertion site while that port is accessed. Always using proper skin antisepsis, whether it is the patient or a clinician that is preparing the port for access. Those are the measures that are going to help prevent infection in the long run. And then doing everything you can to keep that dressing clean and dry and secure for the duration of the time that it's accessed. If you're not already using one, you would want to consider talking to your prescriber or your clinician about using an antimicrobial disc at the needle insertion site to prevent infection and inflammation. And I would really encourage anyone having issues with their central venous access to work with your clinician. An experienced clinician is going to have creative solutions that might work for you. Maybe something that you haven't thought of before. We get in a habit, and I've got my friend Chester here that I've dressed up for you. And we get in a habit sometimes when we're dealing with our access that we just dress it and put our tubing straight down. And one example that you can use is, what can you do with the tubing to minimize when you're hooked up and you're gonna pull on this tubing? What can you do with the tubing when you access it to kind of loop or curve the tubing, or do something with your dressing that's going to help you to minimize that rocking and pulling? And I'm sorry, but Chester's skin doesn't stick too well, so it's not the most beautiful dressing in a camera, but it's just one example that I've found over the years that when we can work with a patient and do something to remove that pressure, it can make a big difference in the healing of that port site when the needle's removed.
Thank you, Sarah. I think that was really helpful to see as well. Do you have anything to add, Dr. DeLegge? Any recommendations for the granulation? No?
No, I don't. They're doing a great job.
All right. All right, well, let's shift gears and move away from the clinical for just a minute. We had someone who wrote in and wanted to understand navigating air travel with an NJ. So for those of you who don't understand the language just yet, we may have some newbies on here or some folks who aren't as familiar. That's a nasojejunal tube that goes in through the nose. So Michael, could you weigh in on that?
Sure. Thanks, Amy. I'll try to give some information that applies to not just feeding tubes, but also traveling with IV therapy as well. The first thing to remember is the TSA and the airlines are not connected. They're under separate entities. So regarding screening with an NGA tube or anything that the TSA terms as an external medical device, IV line, ostomy, they'll most likely have you touch your dressing and then test your hands. That's a common practice for screening those kinds of tubes. They may also do a pat down on you. They're trying to be less invasive during COVID, but they may do a pat down as well. The best thing to do before you get to the airport, though, is call TSA Cares, go to their website where they have an online form, or have your patient advocate do it, and request assistance from a passenger support specialist or a supervisor. They get more training than the regular officers to help people with medical conditions and disabilities. And it's a big deal with liquids over the 3.4 ounce limit if you're carrying those through security. They need to screen everything. Frankly, your documentation doesn't matter for TSA. It's about them being able to screen all the liquids you have and what's on your body. And you need to communicate with them, leave enough time for screening, and kind of go with the flow, because it can be different from day to day at the same airport. The one other thing to remember is regarding on the plane. Frankly, our patients report more problems with airline personnel than they do TSA. Try not to exceed the carry-on limit. They don't care what you're carrying if you don't exceed the baggage and weight limit. And if you do need to, call the airline ahead of time, talk to a manager, see what their policies are about waiving baggage fees for medical baggage. If you have only medical items in a particular bag, many airlines will waive that fee. For enteral patients, they often will take a certain amount on the plane with them they feel comfortable with for that day in an emergency and check the rest. For TPN, we don't recommend checking TPN. Carrying it with you is safer on the plane. And so those are the main points to remember. And for international travel, it is good to have documentation, a doctor's letter, how long you'll be in the country, that you're medically stable to carry, and a list for all your carrying to show customs officials and international security officials, which differs from country to country. And unfortunately, there's really no control we have over that. So just be prepared as possible for that.
Thank you, Michael. Great tips. I see a question in the chat. I think that kind of goes along with this. So Brittany is asking, is there a TPN that is shelf stable and does not use soy? She says she's found she can't travel or currently safely, whoops, just moved on me, sorry. Or it might have moved to the answered questions, I'm wondering. It did. Someone already answered it on our team. Thank you, Leah. So for the rest of the group, you can look to the chat and we'll move to the next question since Leah answered that so succinctly. All right. So the next question is going to be for Crystal, our pharmacist. And we have a consumer asking, what's most important to you when choosing the infusion pump that will deliver the PN?
Okay. So first, the most important thing when choosing a pump for our parenteral nutrition patient is their comfort level of using a particular pump. So normally what happens is our clinical service liaison, our nurses, they'll go to the hospitals, will talk to the patients, and they'll also review the pumps with the patients to do a teach and to see which pumps they feel comfortable using at home. This will be relayed to our team, us, and then we'll discuss which pumps would be best for them to use at home for their TPNs. Based on the patient's history also, if a patient has a preference for a certain pump they've used before, we would go with their preference to accommodate them as well. Other considerations would include the reliability of a certain pump, the ease of use for the patient, and also the ability for the patient to be mobile while they're on their parenteral nutrition as well. So those would be some of the things that we would look into prior to choosing which pump they would use.
That's great, Crystal. Thank you. What would you recommend if you're someone who's currently on TPN and you're having challenges with the pump that you're using currently?
First would be to contact us, the clinicians, to review exactly what errors they're having with the pump. There are certain errors of occlusion, down occlusion, or certain other errors that could have happened that we could actually troubleshoot on the phone with them. And sometimes our nurses that go out to the patients will also troubleshoot it with them as well. So please contact us with any errors or issues with the pump.
Yeah, I think it always comes back to that is, the home care nutrition team is here to help you. So any of those types of challenges are things you should be able to bring your home clinician, and hopefully they can help you troubleshoot that. Thank you, Crystal. Okay, so we have some questions about feeding tubes. This is a hot topic these days and for many different reasons. So the first question here for Janelle is, why did the style of feeding tube change from the one which lasted almost a year to the one that has to be changed every 3 to 6 months? So this sounds like a question about a low profile tube maybe.
Yeah, low profile, or I'm wondering too, usually the first feeding tube placed is a surgically placed tube. And so I brought a visual. So the end of that tube, the inside, we call it the bolster. It's what holds the tube inside the stomach, is this solid piece of little mushroom cap. When this tube has to be changed, they usually use what's called a balloon style replacement tube. And the benefit is that you can change it quickly. It's not a surgery to change the balloon style. This is what one looks like when it is not filled up. So they would pull out the old tube, insert this balloon style, and then they fill that balloon with water. And this is a soft silicone balloon. And so that's what actually dictates the life of that balloon. It's that balloon that has that 3 to 6 month life to it. And so once that balloon degrades, that's what requires that change in tube. So I think that that's what was being asked there. And it's really that balloon life. But the benefit is it doesn't require surgery to get that replacement tube in.
Mm-hmm. Yeah. And then there was another question about tubes. Someone asked, does a Jpeg or a G tube need to be replaced at regular intervals?
When I think of a Jpeg or a PEG, again, I'm thinking of this surgical style tube. And I have had patients who've had that tube in for 3 or more years, and I've had some who need to change it every year. So it really is about the condition of the tube. And so long as the tube, you can flush and feed through it, there doesn't seem to be like mold growth or black spots on the inside of the tube that could indicate mold or perhaps a yeast growth in there if the tube's not degrading. So long as that tube continues to feed and flush, there's no need to change it. And the best thing you can do to extend the life of your tube is just regular flushing. So always making sure you're starting and ending a feed with water, flushing between each medication. Those are all things that are going to help that tube stay clear and extend the life of that tube.
Thank you, Janelle. One more question for you. What are the latest updates for NFIT and how is it impacting DME companies?
NFIT. We've been talking about it a long time now, guys, right? Since 2016. I can say that my experience with NFIT is we have thousands of patients who have successfully moved to NFIT. I would say year over year, we're seeing increased growth and rate of people moving over to NFIT and doing that successfully. We still have a lot of people using legacy tubes. What I do know is that there are some deadlines that were put out by GEDSA, which is the group that's advocating for NFIT and working with many of the manufacturers. And we're approaching some of those deadlines where we are going to start to see some of the manufacturers limit their legacy tubes. They're going to stop production of them. So in the market, what I expect to see here early in 2022 is that we're going to lose access to some of those legacy tubes and transition connectors. That is going to cause an increase in the move to NFIT. And we're going to see more and more of that as we move forward. And I know for us as a company, we're starting to plan on how can we proactively start moving patients to NFIT before the devices are no longer available, those legacy devices.
Very important. Okay. So wanted to shift back to TPN for a minute. I think this is a question that probably most people who have started TPN will want to hear about. So I'm going to send this one over to you, Leah. Leah, at what point do you think a patient can transition off of TPN? And I think I'll add to this patient's question, is this a possibility for all people on TPN or just for some?
Yeah, it's a very individualized case-to-case type of thing. But if you don't have any kind of odd or extenuating circumstance, malabsorption, things like that would need, not just long-term monitoring, but, very close follow-up. If you're just recovering from a surgery and are on TPN for that, for example, and then you start tolerating about either 60% or more of enteral or oral intake or both, that's when we can start to talk about weaning the TPN. But like I said, that was a very broad answer, and it can be very specific in case to case for the patient. So.
Thank you, Leah. So, if you're feeling like you're making some progress with your TPN, you definitely talk to your physician about that. It might be time for you to start thinking about strategies to wean. And certainly your dietitian is going to be collaborating in that conversation as well. We have just 1 minute to go. It seems like it's flown by and we've barely gotten to any of your questions. I wanted to go ahead and say that we will do our very best to answer the remaining questions and get that information back to Andrea to share with all of you. I want to thank everyone who sent in their questions in advance. Thank you for the great questions also in the Q&A. And thank Andrea for allowing us this time to speak with consumers.
Well, a huge thank you to the whole Coram team here. You guys did a wonderful job answering questions. You had a lot of ground to cover and a lot of questions that we really could have been here for hours in order for you all to answer all the questions that you got. And we really appreciate everyone sending all those questions in. I know they were really eager to get them answered. So like Amy said, we'll do our best to get those up on our website for all of you. So thank you again.